Tony York, your host, and a few special guests. I invite you to join me in learning alongside some of the brightest minds in the security industry. And as each month, we love to take a deep dive into an important topic surrounding the safeness of healthcare. Whether you're brand new to healthcare, a second careerist, a recently promoted, or one of the old hands, I think you're going to find these discussions insightful, more importantly, useful. So let's get started. In today's program, conducting a security vulnerability assessment is a basic foundation for most every healthcare security program initiative. Many would say it's a critical success factor for every healthcare security practitioner. In this episode, I'm joined by Tom Smith, CHPA, President of Healthcare Security Consultants, who I'm quite sure has conducted more healthcare security program reviews than anyone currently practicing in the field today. Tom is a court-recognized expert in healthcare security and has led consulting engagements in a wide variety of healthcare environments. I'm saying from the largest organizations you've probably ever walked in that considers themselves a hospital, some of the most intense safety net hospitals that you could come across, to those who have a critical access hospital designation serving rural communities throughout the United States and North America, and pretty much every level of healthcare in between. I've had the distinct privilege of serving on the IHSS Board of Directors with Tom and followed him as president of the association back in the mid-2000s, and then joined him on the Guidelines Council after our term ended. Let me just say this give back from Tom Smith is unlike anybody else in the industry, and he is just simply impressive to watch do his thing. He's been a personal and a professional inspiration to me and somebody I'm really excited to join and have everyone here. But before we let Tom introduce a little bit, let's just talk about Tom, because some would say that Tom's experience when he was inside of healthcare, he sort of has another understanding that he was a little bit of a poster child for some of the CMS's scrutiny related to security staff carrying defensive equipment. But as I think you're going to quickly find out, Tom has a depth of experience that he's agreed to share with us all today that is going to be tremendous value as you think about conducting the security program reviews that you're doing for your organization. So buckle in and let's get excited. Tom, thanks for joining me and welcome to the show.
Gosh, thanks, Tony. That was quite an introduction. You took a little license here and there, but I appreciate it.
Hopefully folks are going to ask you a little bit about what that CMS poster child is, because obviously you've got a face for radio, so it's a wonderful opportunity for all of us to work together. But you know, Tom, let's give us the audience a little perspective. I mean, you and I first met, I think it was in the mid-90s. I want to say 95, 96, through a mutual acquaintance. I think you were about 10 years in your career, if I recall at the time. But in that time frame, I mean, how many reviews do you think you've actually performed for hospitals?
Well, I couldn't really say. It's been hundreds. I've been in hundreds of healthcare facilities. Now, some of them would have been a healthcare system where there's 6 hospitals and 25 clinics, but it's safe to say hundreds of healthcare facilities over the years. And yeah, I'm old. I started in 1981.
That's amazing. Experience has taught you a lot, right? And then with that age has come some wisdom and some opportunities I think we can share with today. You know, Tom, it's so funny. I've said to a lot of people doing assessments, they feel like doing a puzzle, right? Except for when you're working on a puzzle, you typically have a box that says, hey, this is what it's supposed to look like. And we don't quite get that cover to really help guide us through what we should be doing when we're doing these assessments. And with that said, learning about an organization, the inside and outside of it is sometimes in this quickened period of time is one of the hardest things I think to do in our profession. Speaking of that, I mean, what are some of your favorite sources? I mean, for gathering information about the threat environment, the security risk the individual healthcare facility faces. Tell us a little bit about how you go through that puzzle making process.
Well, taking a step back, it's primarily in my experience, and I those of you that have seen me in some of the conferences speaking on some of these topics, I always say good judgment comes from experience, and a lot of that comes from bad judgment. And I have to admit, I've shown some bad judgment in some cases, and it's those as a younger time in my career, I learned from it, and it's those those situations that you survive, you learn the most from. But I look at, there are several primary resources, and it's the International Association for Healthcare Security and Safety. There is just a plethora of information available through the website. Most of it's free to members. I was just yesterday looking for a resource, and I went to the website and I typed in the topic, and I found some new stuff that I hadn't seen before on the website. But I also look, it depends on the type of assessment. Emergency departments, there's just all kinds of information about emergency department security through a variety of professional associations. The American Medical Association, the Civil and Nursing Administrative Professional Associations, the MD Professional Association. There's a ton of information there in any security sensitive area. The typical ones, the emergency department, behavioral health, pharmacy. There's just you name it, you go to the professional associations for those areas, and there are there's some very good resources to link into. So I always find some success when I'm assessing a pharmacy, for example. I'll just use that as one. If you use the pharmacy professional association, use their guidelines, and then mingle them in. The IHSS has some pretty good guidelines as well, and you mingle those two in, and you'll come up with something that's maybe more, the pharmacy people are more receptive to if you're quoting them their own professional association, which sometimes they're very involved, sometimes they have no clue, like I sometimes will find something new in the IHSS that catches my eye. Or the Asper Tracy, the Homeland Security. Gosh, there's just a massive amount of free information out there. The Joint Commission has recently updated their information about the security standards that were recently promulgated by the Joint Commission. But along with that comes a ton of additional information that is very useful when conducting assessments. If you look at infant areas and pediatric areas, the National Center for Missing and Exploited Children is another go-to reference. It's been around a long time, but still very, very relevant and viable. In an area where you can see where people always want to know, well, how do I know this this is doing any good? Am I implementing something that is improving things? And you look at the National Center and what the number of infant abductions that we had back in the 80s and 90s, and look at the infant abductions now, and there are very few happening. So those are some of the primary resources. I look at, if you look at information you want to collect beforehand, the CAP Index. I'm a heavy user of CAP Index. Reason being, I have lots and lots of data that over the years from other healthcare facilities that have CAP Index. I've got hundreds of CAP Indexes in the file, and they do a nice job of comparing the healthcare industry. They have a healthcare industry CAP Index that compares thousands of healthcare facilities, and so you can look at your CAP for a particular site, and you see where you compare to other. I can't remember how many. There's probably 6,000 healthcare facilities in the CAP Index report. So, and you can also get deeper. Many local police departments have online sources that do a really good job sometimes of where does it showing graphically where criminal incidents are occurring in relationship to the healthcare system. I find it's always fun where I'll find a new administrator at one hospital I'm evaluating, and they come from what they perceive as to be a very high crime area, New York City or some other area, and I'll be looking at their site where they're somewhere in some other state, and they think that New York City had the highest crime. Well, we show them the CAP Index, and it eases them up a little bit to be more open to potentially thinking about doing some things to enhance their security posture. So those are some of the things I look at in advance of an assessment.
You know, it's amazing, Tom, to think about all the sources that you're actually just paying attention to. I mean, from IHSS to the other trade associations that have a safeness, security type of implication, ENA, ASAP, ASHRM, I think are all areas that I'm sure you're probably looking at. I find it very interesting, Tom, that you're actually trying to pull local police stats. Obviously, when we're trying to compare facility to facility, especially if they're going across jurisdictions, it's a little bit more of a challenge, right? I mean, not everybody reports crime stats in the same way. So when we're trying to look at an apple to apple comparison, sometimes we get a little bit of an apple and banana comparison there. And although it still tastes good together, it still doesn't always really give us the insights. And I'm sure you're probably the same as me, as why you started working on the Crimecast, right? With Cap Index, started looking at the comparability of that. So I've got a couple questions in that sourcing, but Crimecast specifically, I mean, you've used those reports a lot in your past. You're comparing them to other facilities, but what do they typically inform you about? What are you seeing that's stemming from the Crimecast that's really informing your thought process as you're assessing these organizations?
Well, I have to back up a little bit. I also really pay a great deal of attention to the incidents that are happening on whatever property we're looking at. I don't want to give you the impression that I'm just looking at crime stats, but yeah, I look at, if I just ran a bunch of cap indexes in for a site I'm looking at in December, and it gives you a general idea of the relative risk of crime in that immediate vicinity. So that, in addition to the information from the healthcare facility, whatever their incident system that they use for tracking incident, and we'll get into that later, I hope, because there's some real problems with some of the internal statistics that we can get if we're not careful. But I look at the CAP index and the local police. It just gives you a general picture of relative risk of crime. I often find that the locals don't pay attention to that. They don't. They're not, again, for whatever reason, and it's not a complaint, but they're not tuned into those types of incidents that are happening in the immediate vicinity of their facility sometimes. Or if you do run a criminal incident report, a forecast for a site, and you go to the police department and ask how many incidents have happened, at this address, you can get all kinds of incidents, but they tend to be incidents that happen somewhere else, but the police took the report at the hospital. So you have to be a little careful. And that's always a suggestion I have for people is, gosh, make sure you're getting a copy of every report that's taken from your address and parsing it out. Did it happen here or not? And making sure the locals know that, it didn't, because it can come back to you if you have an adverse incident at your hospital and somebody hires somebody like me or another expert, and they will certainly get that information, and it can make it look much worse if, say, 30% or 50%, I've seen higher, the incidents for police take incident reports at your hospital, and most of them didn't happen at your hospital, but it makes it look like it did. So it can make it look really bad to a jury if you had all these high violent crimes, happen at your hospital when in fact they didn't. And it doesn't matter to the plaintiff's attorneys. They'll make it look like it did. Oh, well, sure, it didn't happen there. So it's nice to correct that as you go, as opposed to waiting until the criminal incident occurs.
That's such
you're in trouble.
Such a good point, Tom. I mean, the defensibility associated with where your data sourcing is coming from,
right?
It's not clear for everyone, right? They're thinking, oh, I've had all these events happening at my hospital, when in fact, no, it was just where they were reported at.
They happened elsewhere
in the community.
I don't find a lot of people checking those on a regular basis. So I always suggest, well, you appoint somebody in your chain of command responsible for checking those things on a regular basis.
Yeah, you're so right on. And when you think about, though, and you're thinking about how those are community events, how the Crimecast, how all of that really works, I've always tried to share with folks, especially, I've had a chance to work with a lot of these early careerists that are coming into healthcare security with a pre-conference workshop that IHSS has asked me to host for years. And I say, when you start thinking about the pie of 100% of all your available security resources, oftentimes we dedicate so much of our resources to the internal environment. typically somewhere between 75 and 80, whether those are people, processes that we're writing for technology and education we're giving, or the technology that we're providing. It's amazing to me, Tom, that, when you start seeing these higher indices, these higher scores, what does it really help inform for me is, hey, what's going on in the external environment, and is that the right type of proportion of that pie that I should be dedicating to the external environment? And in so many ways, it's been very helpful. I mean, from things that we're doing for just the focus on lighting to, going into an organization, and I'll never forget the first time I actually met a gate. And it felt like going into a residential community when I was going into a hospital in Florida, and it was a gated environment. And once I looked at the CAP index score, it made perfect sense of why they wanted to have control at the furthest level they could at the point of entry into their environment. So it is amazing how those things can allow us to look at that. But Tom, there's one other area that I know that you and I share in commonality, and that is we do a lot of interviews of staff, department directors. We do a lot of interviews with some of the frontline staff themselves that aren't just giving us the sort of the known answer as much as the real answer. So, when we're trying to compare, hey, is practice and policy really in alignment? Is always an important step of this exercise that we go through. But tell us a little bit, what's some of your favorite questions to ask those leaders and those frontline staff? What are the ones that get you sort of the answers that really give you some of the really knowledgeable nuggets that you can sink your teeth into?
Well, if I have my way, I like to ask questions in advance through a little glad you asked kind of an employee questionnaire. And I know sometimes people are overly surveyed, and sometimes there's a resistance to doing another survey, but I find people are interested in answering those surveys. It's pertaining to security. So I like to ask, and certainly anybody could do this. The Survey Monkeys are, those are really easy to put together, but I like to ask, do you feel safe? Yeah. And then after somebody's answered that, why? And, whether they feel safe or whether they don't feel safe, I want to know why. And it's a simple question with a follow-up response, and sometimes there's some very insightful answers to those questions. And then I like to ask, where do they feel most vulnerable? What are the areas that need security attention? Do they have any suggestions for enhancing security? But I also like to begin with, before they get into what they want to change, I also ask, what's working well? What is working well from the security perspective, and what do you like about the security program? Try to get people to say some positive things, because everybody's seems many people have an axe to grind, but you'll get a pretty good perspective from people as to what do they like about it, what do they want to keep, and then another kind of a final question, wave your magic wand, what would you do to enhance security? What kind of changes would you like to see? And so it depends on who you're asking. If you ask the senior leaders, sometimes you'll get different perspectives and answers, but if you ask the line staff, I always try to capture those responses, and again, ideally, I will have a Survey Monkey type questionnaire that is sent to the employees of security sensitive areas and the night nursing supervisors. I always like to include the night house supervisors, the emergency department charge nurses, and those folks are never shy to let us know what they think about security, and they often have some really good suggestions.
Isn't that amazing? I don't know what it is in the water of their training, but no question about it. Those are two groups that never are typically shy about giving us a perspective, which obviously makes them wonderful folks to interview, to talk to really get their insights. And you mentioned something about thinking about what's working. I've always been a big believer, and I know you and I have been through the 2+2 exercises in our past, where you're trying to get both sides of the brain working, right? Hey, two things that are working in the program right now, and two things knowing what you know right now, you do differently, and you use the magic wand. And I love that one. I have found that is amazing, and it's interesting to me that
I probably stole that from you, so you got
well. I'm not certain about that, but you know, it's probably my kids' love of Harry Potter back in the day. But in saying that, though, Tom, I mean, isn't it just interesting to hear that so many times asking that question, the changes that are being requested aren't typically major investments and $1 million worth of new technology or some major modification to a policy. They're usually small little kneeling. I remember a recent conversation when the nurses were just asking, like, hey, could we just get a full set of restraints? And I look around at the folks that were hosting me, and they were all a little bit baffled of saying, what do you mean a full set of restraints? Well, yeah, we only have 3. And nobody knew it, and nobody had any that were the wiser. And, you know, that was such an easy correction, but at the same time, it's just a part of going through this effort of asking that question, and getting that insights from it.
It does lead to other questions oftentimes, and sometimes in unexpected ways. A good one is I got back, well, like you're saying, they want more restraints available. One was, gosh, we can never find any spit socks when we're getting spit all over, and where can you find a spit sock? Well, okay. Do you have a policy on use of spit socks? What kind do you use? Are there circumstances when you shouldn't use, so then it leads to another question in their policies and procedures. And I'm not saying you should or shouldn't use spit socks, but if you use them, you need to have a policy on it.
Well, absolutely, right. I mean, and then we got to make certain the practice and the policy have alignment is probably one of the biggest common issues I see inside of healthcare of hey, where is the disconnect?
Sure, are the devices approved by your medical device committee? Is it a restraint? I mean, there's some questions to ask, and they're better to be asked and answered before you have an adverse event. Because patients come in with spit socks all the time. The EMS brings them in in a spit sock, or the sheriff's department or local police. And well, what do? You keep it on? Well, you know, they're a spitter. And at what point are they under your control? And then do you put a spit sock on? It just answer those questions in advance, because that all came out of one of these surveys before I arrived for an assessment. The employees wanted more spit socks, so the answers lead to other questions.
Just pull on that string and that thread, right, and see what pulls out with it, right?
That's
exactly. Amazing.
Exactly.
So I got to ask, Tom, I mean, just hearing this particular conversation, you bring up spit socks, but I can't imagine that's the strangest thing you've ever come across. What's the strangest thing you've seen doing an assessment in healthcare?
Strangest thing. I've been to a few places that it's maybe like going back in time, and where someone's and through no fault of the security director, they just hadn't been professionally developed and couldn't. And I've just seen some, you would think you're back in the 50s, where people were being put in cages and chained to the wall, and they never had a CMS or a Joint Commission survey, or they didn't show them that part of their facility. It's all I can say. But seen some pretty odd things in that kind of situation. People doing things that I never thought, again, modern day, and back in the day when I started in 1981, there were some things that we did that we've learned over time, and the rules have changed in many ways for good, and in some ways the regulators have thrown the baby out with the bathwater too. So I think just the common sense needs to come into play, and I guess those are the strangest things I've seen, is just the folks not paying attention to what the rules are, and maybe they hadn't been professionally developed, or maybe they couldn't. Maybe that was what their organization called for. I apologize. Yeah, okay. I'm back.
Yeah, you never lost us, Tom, so no worries. It's interesting to hear about professional development of the staff, and one of the things I see is sometimes they don't really like have this appreciation for how to manage the perception of safety, the perception of how secure the environment is. They may do okay with the kind of people, but then you look at it. I'll never forget the time I came across I was in a waiting area, and I think I was actually truly waiting on someone to either grab a water or something, and it was early on, and I look up and I'm looking at this television monitor, and I'm like, what's that behind it? And right behind the television monitor was a pretty decent looking video camera. I'm pretty sure at one stage it was probably used for security surveillance of that particular waiting area, but I think the only thing they were looking at is what auxiliary jack was needing to be left unused. But anyway, it was sort of mindful of this mindset that what's that message given to people? I've had other instances where I saw a security patrol vehicle that if it was 10 years old, I'm being nice to it, but I think it had 10 years worth of dust because it was sitting in the area of a parking garage. It was up on the curb, and it was just sitting there with just baking in the sun with the word security barely visible, but they were trying to ask the folks that said, so what's that doing? Well, we're trying to deter crime. And I said, well, why do you think something like that's going to deter crime when in fact, really what's happening is this whole mentality of you're just telling people you're not taking your security serious around here. You're actually not giving it nearly the right amount of attention. So you're not managing this perception of safety that really is necessary. So some pretty strange things as I know you've seen, and we're probably being nice about our words here.
You're reminding me of one, and I'll just leave it at this, but we did an assessment of the location that basically they would pay the local police department to be there anytime they could show up. So they were paying the officers on overtime. And we drove in to do a night assessment the first night. I've never seen so many police cars. I thought there'd been a disaster. And there were all these police were there on overtime being paid, and there was no control. And that was just one element of it was all the police all the time, and it wasn't a really big organization, but they were afraid to not have the police. So I think there's some of that going on in our country at this point now too.
Isn't that amazing? Hey, Tom, not quite related to that particular conversation, but I think back to early in our career and you think about some of the greatest risks we used to face. And I know you and I have had more than one conversation about, hey, what's the greatest risk facing healthcare? And I think early on in our career, we would have said the uncontrolled access to the facility. Still at play in many organizations now that aren't really putting that type of emphasis on. Obviously, COVID helped a lot with trying to get control of our access. But over the course of time, has your opinion changed? Would you consider anything else to be the greatest risk facing healthcare today?
Well, it depends on the organization, but I think in general that's still out there. We've found out during COVID that we can control access to our facilities in an improved way. It does take resources. We can close entrances that people never thought they could close entrances. But yes, I think uncontrolled access leads to a lot of these other things, whether it's infant abduction, whether it's assault on patients and staff, other types of abductions, assaults. You look at this incident just recently, and I don't know much about it other than what's in the newspaper. A shooting incident where a visitor came in and was and ended up shooting a couple of employees at Methodist, and well, how do you control that? I think they're looking at really really hard. How can you control who's in your building, and how do you if they've committed crimes, or if they're somebody with a bracelet on, should you let them in? And there are organizations that do that. They to get a visitor pass, you got to present an ID, and then boom, your criminal history, it pops up, certain types of criminal history. So there's ways of doing it, but I think for lack of an imagination, sometimes we have to use our imagination and think about what are the biggest risks and how can we reduce them and how much is it going to cost. But access control, if you can know who's in the building, and I don't want to say limit, but know who's in the building and limit access appropriately. Probably your behavioral health facilities, your behavioral health units, the infant and pediatric areas. There ought to be some controlled access into those locations for sure. So I think the biggest risk is convincing senior leaders that that's what our clients want. That's what patients and visitors probably want more than they know. I think it's an expectation nowadays that you have in certain places that you have higher levels of security. It's expected by the clientele, our patients and visitors. And I think sometimes that's senior leaders will be afraid, gosh, we don't want to do that. We don't want to make it look like a prison here. And, I always say, well, there's ways of doing it without making it look like a prison. Security begins in design, and we're not going there, but I always preach that to begin with, that, gosh, the biggest opportunity we have as healthcare security practitioners is making sure that you're right in the middle of any renovation or new construction project at the earliest phase, because you can make big impacts on security if you can design it properly from the beginning.
Oh, Tom, I want to jump down that conversation so hard because it's the design principles, the layers of protection that can be incorporated can have such an impact. Not to mention the ability to reduce the volume of events that could happen, but we can actually lower the operational cost
Exactly.
by a very significant amount and manage the aesthetics that I think so many desire for, quote, not wanting a security state, or as you say, look like a prison. And, it's been amazing to me to think about the number of times I've heard from hospital leaders that have said, hey, it's not that I'm against it. I just don't like the perception that it's creating. And I want to not look like we're this high risk environment, which I think that's the perception that's changing in society right now, is that people come to an organization, they feel like, hey, what are you doing to keep me safe? What are you doing to manage that for me? Especially in an environment where, what do we really do? I mean, if you're a patient, you get all your clothes taken, you get this gown that doesn't even cover your backside, and you have doors that don't even lock. You have a room that you can't even lock. I mean, it's and they give you some drugs to help make the pain go away that pretty much takes you out of lucidity. And so all of a sudden, what do we find ourselves in? In a vulnerable place. Now, I share that with you and being a little bit excessive in my thought process, but I think it is something that we have to manage.
I think I'm reminded of a couple of other resources also from the beginning of our conversation. The NFPA, a lot of people don't realize the NFPA has some security standards out there, and I think they're guidelines, they're not standards. Some jurisdictions may make them standards and requirements. But for example, if you are a healthcare system and you own a hotel or a place where patients and visitors can stay, you should be looking very closely at the NFPA's guidelines on healthcare. The hotel type establishments. It's not coming to me what it's called, but there's a specific set of guidelines in the NFP just on that. So if you have a hotel or a Ronald McDonald House, those kind of things associated with your facility, boy, I'd really be looking, because those things can help you bump up the need to enhance security where it's appropriate.
Well, we're seeing now, I mean, you think about it, that listing, I mean, you think about the residents that we have in our long-term care facilities, and so many organizations have really created that type of capacity, managing, yes, especially our aging populations, and especially here in North America, which both are trending very similarly in that, with our boomers, getting a little bit older and needing a little more care. The greatest gen, that's still getting a lot of care needs as we look at it. And it opens up a whole new perspective. I mean, I think about, the work that we've been doing in long-term care, which is a lot of similarities to healthcare and hospitals specifically, but a lot of variables too that we don't think about when somebody's truly living there, not just, coming in and being a patient and a visitor for a few days.
Yeah, those residential communities have some very specific risks where oftentimes where the residents, they're at a place where there's a continuity of care. So one day you're just renting an apartment that you're not old enough, Tony, but I am. I could go to a 55 plus residential facility and live there. But as you age and you get, let's say you have an Alzheimer's or a memory issue or some other debilitating issue, at what point do you go to the next level of care? And it's more expensive, and families aren't always interested in that until maybe it's too late and then there's an adverse event, and then how much responsibility does the healthcare facility have for not helping lead that process? So I've had some very difficult incidents in my forensic practice involving long-term care facilities, that case where mom or dad or grandma was fine one day, but maybe they have the sundowner syndrome. Later in the evening, they can't open the door. They can't use their card access reader. They can't use the thing that calls for help. They can't dial a phone number to get back into the facility. So how do you get them back in safely for those people that are really, really diminished mental capacity? So it's a very interesting part of care, but it's really difficult to help organizations help manage that process when grandma or dad or mom needs to move to the next level of care. It's more expensive, and sometimes it's more difficult to get.
Absolutely. And it's emotional for those that are, trying to help solidify that opportunity for the person who needs that care. But I think it's a future trend to watch. I mean, long-term care facilities are growing in volume, they're growing in need and demand. And I think we're going to see that it's an area where we're going to spend a lot more time over the course of time. But Tom, you mentioned something that spurred a memory, and I know how much you have spent personally and professionally on the issue of prisoners as patients. And next month, I'm going to be joined by Brian Warren about this. But I mean, how do you look at the prisoner as a patient and the risk associated with that? We're going to dive in deeper next month, but just maybe a highlight for somebody who I know studied this extensively in your career.
Well, yes, I've unfortunately been involved in a number of these incidents from a consultant perspective and from an inside practitioner, where prisoners commit very high violent criminal acts and they do what they can to escape. I've got probably one of the funniest stories involved it and one of the saddest stories involved in prisoner situations, but it's very dangerous. Prisoner care is dangerous, and I think your policies, I always recommend really taking a hard look at our IHSS guideline on forensic care, making sure that you're following those guidelines. There are several others out there I'm sure that Brian will mention, but gosh, I've attended a couple of funerals involving people that were killed by prisoners who were escaping or had escaped. And it's just the officers and the guards that are responsible for them. Sometimes we all know how hard it is to find quality staff members and keep them. The same as with your corrections facilities, the sheriff's departments and the state corrections facilities. And just because they're in your hospital doesn't mean they're not patients also. They're your patients. So making sure that somebody from the organization is sticking their nose right into that, having a policy and making sure the policy is being followed, because the officers sometimes just don't follow the rules, or they don't know the rules. And there are some very good examples to help make them follow the rules. But after you've had an event at your organization, you're going to be looking at all kinds of things, looking at things differently. Sometimes staff get, they don't like to see the handcuffs on, and they don't like that perspective that maybe they've never been around dangerous prisoners before. And how do you know who's dangerous and who isn't? There's a risk assessment typically done by the forensic agency, whoever's got the custody. But the most dangerous part, based on our research, is when the handcuffs come off, it's game on, or the bathroom. When they go to the bathroom, most facilities require the correction staff to go in there with them, and we have to watch them. And, well, they don't like doing that for obvious reasons. And I have if we had more time, I have a hilarious story about, 6 prisoners at one colonoscopy unit where they were coming in to have a colonoscopy, and you can just imagine no one was injured. There was a lot of risk for it, but it's people don't like to go in there, and the officers will not follow the rules. They won't watch them in the bathroom, and then they go out through the roof, through the ceiling, through a window. They take the toilet paper holder off the wall and hit the officer with it as they come out, or worse. So it's a dangerous time.
Yeah, no question about it. And it's something I think when we're doing our assessments, I mean, right, it's a person who's got a higher risk profile. And we have a lot of that in healthcare, right? It's not just the prisoners that come in as patients. We have things that do. And I know for me, so one of the key messages I try to communicate a lot is, okay, so we're now caring for someone who's presenting a higher risk profile. What are we doing differently? And I feel like that's one of the key things. And the prisoner as a patient is, Brian, as you and I both know, is a wonderful resource and has got a lot of, he's just a great dude who's got a wonderful personality, but he's also got a lot of experience, and I'm looking forward to jumping into that conversation with him.
The last little bit about it is prisoner care. Complacency kills. It just does. Right. And the officers get complacent. The clinical staff that care for those forensic patients are complacent or don't know the rules and don't know their own policy in advance. And the security departments are complacent. Some cases where you're taking care of the whole state prison system is coming to your facility. Probably they pay really well, but you need to pay attention when they're there and make sure they're following the rules. That's
right. And make certain your officers who know the rules as well about, when do they engage, when do they not engage. I have found a few times when folks say, well, we don't help with the patient. Yeah, but we still want to be there to take care of the staff members in case something does happen with said patient. So it's a tough situation.
It is one of the riskiest things that takes place in your healthcare facility, I believe. I did an assessment just earlier this year on a facility where they take care of all the prisoners for the state in their catchment area, and I went there, and it was scary. They needed to pay some attention, and they'd had incidents. So it's one of those really high risk areas, I think.
Yeah, in the high risk areas, I mean, right, that's where there's a lot of attention spent in the vulnerability assessment, right? I mean, when you think about the proportion of time that you spend, I would imagine you're finding yourself saying, hey, there's the general risk and vulnerabilities that, we all need to look at. And then there's those areas, I like to refer to them often similar as Joint Commission. They're the high risk processes that are just occurring, and how do we manage those? Tom, let me switch gears with you a little bit, because obviously this conversation is really important for many, but you're now taking your observations, you're taking all the sources of information, and that's going to funnel into something that's probably going to be recommendations for improvement, ideas for what to continue. Tell us a little bit about, how do you inform your security report itself? What are tips that you've picked up over the years that can just be of benefit for those who may be doing this for the first or second time, and just trying to say, hey, am I giving you every recommendation I could ever make, or am I prioritizing me? Just walk us through that sausage making with us, would you please?
Yeah, well, I try to get that clear up front that I would much rather give people the high level information, and then let them decide what's most important. If I find something, again, a lot of times people ask me to, hey, Tom, prioritize your recommendations. Well, I really don't like to do that, because if I prioritize something and you don't want to do it, or you can't do it, and then you have the adverse event, then now you've got more explaining to do with your plaintiff's attorneys. And these are protected documents as well. The risk assessments are always protected, confidential information, but There are cases where the court system gets their hands on them. The plaintiff's attorneys find a way to get their hands on them. And so I think it's just knowing what the expectations are in advance prior to an assessment and laying the groundwork, knowing what other organizations are doing locally, I think helps with the recommendations. So for example, last month I was at an organization. There was a college nearby. This was a hospital, wasn't part of the college system, but every parking lot in the college has the blue light emergency intercom systems. So whether you're a pro or con, do you like those or not? Do you have to have them? I would say, well, look at the local hospitals. What's everybody else doing? That tends to be what senior leaders want to know. And or the local business across the street. If there's a gate on the parking lot and concertina wire around the parking lot, there's probably a good reason for that. So it always helps to make those analogies and comparisons with what's happening locally. And then if there's some trend that's a wave that's coming in the industry, then letting them know in advance that we think this is what most organizations are doing right now. A lot of it, workplace violence. Everybody's trying to think about what to do with workplace violence. Well, the IHSS has some wonderful guidelines that have been developed over the years. The ASIS has what they call the national standard on workplace violence. So I always try to make sure that we're looking at those really hard when we look at their policies and procedures relating to workplace violence. Workplace violence has been really worked over, but it's still neat. There's a lot of need out there for it. What kind of a threat assessment process do people have? Who's involved? Hospitals are one of the only, and I'm kind of getting off subject here probably, but hospitals normally have all the professionals you need to do a threat assessment. But oftentimes many hospitals don't have a threat assessment team. And then often they'll have a team and they haven't provided them any training. And so you look at the national standard from ASIS, you look at the IHSS guidelines, there's a lot of information there on developing your threat assessment team. So those are the kind of things I like to at least bring to people's attention. Normally that's a place where there's not been any, professional development of the security leader. Mm-hmm. So we always help them in those cases.
So what I'm taking away, especially a large part of the back end of those recommendations, it's compliance with whether they're industry standards or guidelines or other regulatory requirements, right? I mean, Joint Commission here in the States this past year introduced some newly revised language, some completely new language on workplace violence prevention and response. And obviously that's probably not a lot of new stuff for those of us that have been in the business for a while, but for a lot of organizations, I don't think they had been looking at the reporting associated with what should be happening or how to bring education to the forefront and really thinking about who should be getting that type of training for de-escalation and aggression management. It's amazing.
It is amazing that I'm still finding lots of places not doing it. And you touched on something I forgot to mention earlier is incident reporting. I'll go to an organization and I'll find there are 3 or 4, sometimes 5 different places that workplace violence events get reported. The risk management system, the security system, the occupational health system, sometimes HR has a separate system. You've got to combine, you've got to have one source that compiles all that information and looks at it quickly. If somebody reports a threat, you need to be looking at that pretty soon in a reasonable time frame. And the people that look at it should have some training in terms of how to evaluate a threat and what kind of measures should we take, if any. So I'm kind of riffing off that little conversation there, but I just don't find a lot of places are really paying a lot of attention to that yet.
Oh, I'm so happy you brought it up, Tom. I mean, the single source of truth, right? I mean, it's not applicable, whether risk or employee assistance in HR or it's us in security. We have this data collected in so many different places that none of us really understand how voluminous the issues are. And of course, so many of our industry association colleagues would tell us this is still a very underreported issue of violence, which obviously means there's a lot of work still to be done, which is going to keep us.
Right.
I hate to say it. I've said to people all the time, I wish I had to go find job security in a different way because healthcare got safe and it was no longer needed. I don't foreshadow that at any stage of my career and probably through my lifespan, but at the same time, we are seeing a change though that's happening. We are seeing, I think the hospital administrators are taking a lot more interest. Security's risen up out of the basement, and I think they're looking for recommendations about how are we really making a difference. But those recommendations aren't just about adding more people or just more technology. They're sort of the what I call the trifecta of people, process, and technology. And I think it's important that folks are really hearing it. And the thing that I'm finding, especially is if you bring a CFO or someone of that type of financial background, what they're wanting to know is, hey, is there a strong cost benefit analysis? Did you look at other alternatives with those recommendations? And that may not just be for you or I as the consultant, but I think for the practitioner that's listening to us, I know it's critical that they're saying, hey, what risk is this avoiding? What are we really trying to say, can we do without? Is there another alternative? And I feel like one of the things as we make recommendations to the hospitals is to allow ourselves to think about not just what might be first and foremost in our mind, but what other alternatives are there to getting to the outcome that's desired.
Yeah, I can't disagree a bit, Tony. I think there is more receptiveness senior leaders, but they want to know what's the hospital across town doing, or who's requiring this, and what happens if we don't do it. If we accept the risk that you've identified, maybe we'll do that. Many places will accept the risk, and that's okay. I think that's just it's better that they know what the risks are and take reasonable measures, the ones they can afford. But a lot of things don't cost a lot of money. Some do, but boy, I would certainly want to suggest that they do the ones that don't cost much. As I said, hospitals have social workers. They tend to have access to behavioral health leaders. They have access to the police. They've got people with experience. You just have to organize those threat assessment teams.
Absolutely, Tom. Kat Kemper said last month she loves to exhaust the low cost, no cost options out there, which I think was well said in sort of when we think about what are the mitigations that we can deploy. But, you know, as I didn't mention it earlier, but I think one of the earlier conversations I like to have is in some opening conversations, especially with the executive team, is, you know, getting them to talk about their expectations of the security program. But as importantly as what you just said is to start talking a little bit about their risk tolerances. What is it that they're willing to accept? And, you know, once you start combining those two conversations, it's amazing to me that we start getting light bulbs flashing on that say, oh, wow, I've never thought about it that way. They're thinking about things in just a pure and tactical security perspective. And I guess one of the things I have found about recommendations is go a little bit beyond just the security implications and really tie them into what might be the culture of the organization or some other strategies that they're doing for talent management or other aspects that can really benefit the organization, and not just talking about the locking of a door. Maybe it's a better patient experience, you know, or a staff experience at that.
Yeah, I've had my favorite CFO tell me, Tom, why do we need more security than the local shopping center does or the local movie theater? And I thought, gosh, I haven't done a very good job educating this one yet. You know, that you have to really educate what the risks are here relative to other things in other organizations. So, I mean, that's sometimes you have to gauge that. What's the level of the organization's understanding of what the risks are? And you can't expect a senior leader like that to know, you know, some of the details. And I think most of the good ones will listen.
Oh, I agree with that, Tom. And we got to remember that most of them haven't been educated in their formal training leading up to the roles that they're playing. So you hope they've had a good teacher along the way, someone who's out there as a good practitioner that's really taught them and they didn't have to learn some of these hard lessons through experiences that, you, I, and others on this call have had to deal with. But Tom, we're coming close to the top of the hour, and a couple questions out there. One, I mentioned Kat Kemper a moment ago, but she's asked a great question. Are there typical trends that you see when you're doing your vulnerability assessments? What are some of the very uncommon trends that give you pause and we should give attention to?
Wow, Kat would be asking those difficult questions like that. I think one trend I'm seeing is there's more receptiveness. We've kind of touched on that already. There's more receptiveness from senior leadership and listening to recommendations and taking things a little bit more seriously. I think that's a trend that it's a welcome trend, I believe. Uncommon trends that give you pause. I think, again, every now and then I'll go to a place that just hasn't professionally developed their senior security lead, and it really gives you pause when you walk into a facility like that and they're doing things that are, and I try not to be too preachy, and I don't want to turn them off. And we've been hired to help them, but sometimes when you walk into a site and it's all police all the time, and they're working in hospitals, there are good hospital police-based organizations, but there are some that just don't have any idea they're police, and they haven't been taught and trained, and they're being made into security officers on an overtime basis. And those places, that it's not that uncommon, I guess. But boy, we need to tentatively bring those vulnerabilities to their attention.
Yeah, I think you're bringing up a great point. I mean, getting educated and being an educator is such a critical part of what we do every day, right? I mean, and is paying attention to the trends, what's happening. But that's not just us in the consulting arena. It's us as those that are practicing, whether it's a shift supervisor who's managing that particular shift or anything of the like. And I think it's important that we really maintain that mentality that, hey, this is an everyday learning job. You've got to be one that's picking up information and synthesizing it, but you also got to share what's happening in other locations, and how are we able to help others understand the risks that they're facing and the consequences, I guess, of their decisions. Tom, I got another question up here. And maybe we'll make this the last one before we close down, but we were talking earlier about the law enforcement events that are happening in the report, but when we think about what happened at the healthcare facility versus the report being written at the facility, Matthew's asking, is that located in a block of the report, or maybe help us understand a little bit about how we could be able to discern the difference between reported at versus happening at?
Yeah, I think having a good relationship with someone at your local law enforcement agency doesn't necessarily need to be the chief or the senior leader, but a squad commander or somebody in that agency, meeting with them in advance, trying to determine, look, we need to parse out these incidents, because I guarantee you 75% of the hospitals, this happens. And you need to have a process for evaluating that. Turf that assignment to one of your supervisors or assistants, and have them work with the local PD, because if they take a report at your site, you won't necessarily know it unless you ask. Or there's a lot of online information nowadays that makes it way easier to do this. But I would have a good relationship with someone at the PD.
That's great advice, and something to really evaluate too when we're doing our assessments, right? What kind of relationship is existing, and how does that work, and how does that impact the resourcing of the organization? I mean, I feel like we could take this conversation for about another 3 hours.
Yeah, that's an interesting one.
But Tom, let me say thank you for spending some time with me, spending time with this audience. Brother, your insights and perspective are just full of food of thought, and I knew the conversation would be a good one for us just to jump into, and I hope this audience understands just how much you've given back to our industry, and for me, please know, just respect it immensely. And for those of you who've ever read the security design guidelines for healthcare facilities, you're looking at the mastermind here on the screen, and that's not me. That's the guy I'm talking to. So he put that pilot project together and had put it to charter and really rallied a lot of resources, and it's having a tremendous difference in how safe healthcare is being. So Tom, thanks again for joining me. Let me just say, you're such a professional. I look forward to seeing you very soon. And for all of you out online, stay safe, stay diligent, stay aware. And as mentioned a little bit earlier, please join me next month. We're going to jump into the conversation about prisoners as patients, and where we're going to be joined by Brian Warren from Warsec Security. He is another fantastic resource inside this industry that will really talk about the unique risk when prisoners are patients. Tom, thank you. You take care.
Thanks, Tony.
See you all.